starting with the primary injury, first you will have focal ischemia if there is a direct damage to the blood vessels. Then due to the cerebral edema and increased intracranial pressure, there will be impaired cerebral blood flow. And due to the activation of several molecules, inflammatory markers, there will be microvascular dysfunction, and sometimes due to the small vessel bleeding, there will be multiple thrombosis. So all these things will cause secondary ischemia and hypoxia to the brain. So when it comes to the main management of head injury, out of all the things, several things of secondary brain injury, these two things are the main targets that we can manage at this moment with either medical or surgical treatment. Then there are other things like excitotoxicity, where like excitatory neurotransmitters such as glutamate will be accumulated excessively in the extracellular space. These will in turn cause cell death due to apoptosis and necrosis. But still, treatment for these problems are at the experimental level, and we don't have any robust evidence to definitely use any substance, but still people are trying to find pathways to correct these things. And the other thing is the inflammatory response. Again, same like the excitotoxicity. All these cytokines will cause further disruption of the blood-brain barrier, and there will be neuroinflammation and secondary brain edema, as well as due to these inflammatory responses, there can be secondary neuronal injury. Then one of the hallmarks of mainly for the diffuse traumatic brain injury, it's the diffuse axonal injury and white matter damage. So this will cause disconnection between neurons, where the patient's cognition and functional deficits will be aggravated due to this injury. Sometimes the problem with this is the patient will not have apparent abnormality in their non-contrast CT brain, but the patients will have significant neurological deficit disproportionate to the CT brain features. So out of all these things, the first two things we are trying to manage at the moment via medical and surgical treatment, but these things we are trying to manage, but there's no hard evidence to for the management for these issues. So early management and stabilization. So any patient who is coming with head injury, this is something very important for all the junior doctors and primary care doctors. So we can't even think about brain or preservation of the neurons unless we stabilize the patient first. So if the patient comes with both head injury and thoracic trauma or liver laceration, which is going to cause hemodynamic instability, then the priority will always go to first stabilize the patient rather than the head injury. Because even though you go and try to evacuate a blood clot or try to do decompression, if the patient has ongoing hemodynamic instability, that is going to cause continuous secondary brain injury. And so airway management and ventilation to ensure to prevent hypoxia as well as hypercapnia. That is the primary thing. And like before thinking anything related to non-contrast CT brain or any other management pathway, any surgical pathway, this is the most important thing. So in any patient, like this can go vice versa, because in a severe brain injury, the patient, if the GCS is low, then patient cannot maintain the airway, and this can create a event where the hypoxia will be aggravated by the head injury itself. So patients who are having low GCS, we have to go for immediate intubation and secure airway. Then the next thing would be to go for hemodynamic stability, because most important thing, like I said previously, is we have to have adequate perfusion to the brain to avoid the secondary brain injury. So, like for that, we should have a goal-directed therapy where we should have adequate perfusion, but without causing significant fluctuation of the blood pressure to cause more bleeding inside the brain. So after stabilization of patient, then the most important thing that to categorize our patient into with severity of head injury, and to decide the management, then the most standardized assessment tool that we have is the Glasgow Coma Scale. So we will assess the patients with the response to the eye opening, verbal response, and motor response, where we will assess three areas of brain cortex as well as the functions of the brain stem. And with this, we can categorize patient into either mild head injury, moderate head injury, or severe head injury. So when the patient's GCS start to become 13 or less, then we have to consider this patient might be developing something significant. And then we have to go for non-contrast CT scan after stabilizing the patient. So this is again a diagram to show what are the things that we assess in patients who are having head injury, to how to assess the GCS. So for the out of these things, uh, different patients can have similar GCS, like where the GCS might be 8, but depending on what is the individual number for the eye opening, motor, and verbal, the importance of this number can change. So when you present your patient's GCS, as a neurosurgeon, that we like to hear what is the eye opening, what is the motor, what is the verbal, separately, rather than having a cumulative number, because sometimes it doesn't make any sense, because there may be a patient who is coming with either localizing, but other things are less, or sometimes there may be patient with a cumulative number which may be like 7 8, but patient who can localize is much better than a person who has low GCS but cumulative weight. So depending, it's like that. So better to present with the separately for the eye opening, verbal, and motor response when you are presenting a patient to your seniors. Then the management mainly goes with the control of the intracranial pressure, and this will be discussed in detail by Dr. Chula. So basically, in a patient who present with severe head injury, what we are going to do is, after stabilizing, we are going to do a CT scan. So if a patient have a significant hematoma, then we can decide directly whether to take the patient to theater and evacuate the hematoma. But if the patient have diffuse edema, then we have an option either to check the ICP, intracranial pressure, and with that, to medically correct the intracranial pressure or to go for a decompressive craniectomy. So either to go with the medical treatment or surgical treatment, that we can decide if we have a method to measure the intracranial pressure. And this will be discussed in our next lecture. So optimization of cerebral perfusion pressure, it is associated with management of the intracranial pressure as well. And to ensure the adequate perfusion pressure, so at least cerebral perfusion pressure around 60 to 70 is recommended. And sometimes we may have to use vasopressors to maintain this, maintain the mean arterial pressure and fluid management if the patient, especially patients who are presenting with polytrauma, until we can correct the anatomy, we have to correct the physiology to prevent further progression of the brain injury. Then the other strategies related to the control of secondary brain injuries, the control of the temperature, glycemic control, nutrition, and control of seizures if the patient is developing seizures, as well as to go for thromboprophylaxis and physiotherapy and patient mobilization. So with that basic ideas in mind, we will discuss two cases which are relate like common presentations of head injury, and where we have to decide on surgical management and what we are going to do and how to make that decision. So first case, it is a 35-year-old male, and while he was trying to clean the roof, he was fallen from roof and then developed primary head impact. So on presentation to the hospital, he was stable hemodynamically, and there were no other injuries noticed. He had an initial concussion where like you had a brief loss of consciousness, and then he has regained his consciousness, but the patient is drowsy. So in these kind of patients where the patient does not have any polytrauma and visibly there's only pure head injury, then we can directly decide upon the patient by doing an uncontracted CT brain. But if you are from a peripheral hospital, then there are few decisions that you have to make, such as like whether to keep the patient in your institution rather than transferring the patient to a tertiary care center where there's availability of a neurosurgeon, or if you are from a, provincial like district general hospital or provincial hospital where you have the facilities of CT, then if you find something, then what to do with that, and then how to transfer the patient if the patient is started like have GCS more than 8, where you have window, therapeutic window, but you are not sure whether the patient is going to lose his GCS and lose the airway while transferring or not. So to decide on these things, one thing that you have to consider is the uh, patient's the mechanism of injury. So any patient who has fallen more than the height of their own body height, or else if the patient presented after a high velocity injury such as a road traffic accident where the collision impact is more than 40 kilometers per hour, these are rough guidelines to decide that patient has had high velocity injury or severe mechanism of trauma. In these patients, even though the GCS is regained up to 13, 14, you have to be very vigilant because in Sri Lanka, the biggest issue is transferring a patient. So even though like where I have worked in transferring from Vallawai to Badulla, sometimes patient has to go to first Monragala and then come to Badulla, and it has taken sometimes 12 hours to decide everything. So sometimes, as neurosurgeons, we prefer, even from a primary care center, if you can just describe the patient to a neurosurgeon or the on-call neurosurgical MO, then we can advise whether to go this whole round or whether directly to transfer the patient to us, because we know the injury pattern in our patients. So just keep that in mind for the junior doctors who are working in stations where you don't have much of facilities, and when you have to make a decision. Because all of the like most of our neurosurgeons, we are happy to get a patient early, even without a CT, rather than having a patient with everything done, but with GCS3, where we cannot do anything and we have to transfer the patient back. So in this patient, because of the height as well as the primary head impact, we went ahead and did a non-contrast CT scan. So this was the finding. So patient start, like while we were waiting to take the patient to the CT, the patient started to deteriorate and develop seizure, and then we had to intubate the patient, and this was the finding in the CT scan. So he had a very large clot and large extradural hematoma, and we had to immediately take the patient to the theater and do the evacuation and decompression. So in these patients, the something that you have to understand is like the mechanism of trauma, where if we compare extradural versus subdural hematomas. Sometimes, even though this looks really bad, the patients with extradural hematomas survivability is higher than the subdural, because the disruption of the normal parenchyma is less in extradural hematomas. So with these kind of patients, so mainly the treatment will be to go for the surgical decompression and evacuation of hematoma, and then this is mainly for the surgical trainees. Like in foreign countries, you have an option to put the bone flap back. But if you are going to put the bone flap back, if the brain is not bulging, not in this case, I'm telling about in general. But you can, like, if you want to put the bone flap back, you have to have a way of measuring the intracranial pressure. So sometimes in the National Hospital and other hospitals, we have intracranial pressure monitoring devices, but most of the time we don't have. That is the reason that we can't do that. But just keeping it in mind, if you go to a country like UK or any other country, there will be people that who will do that for like subdural hematomas, and so we can put the bone flap back and avoid a second surgery. Then this is the second case, another common presentation where it was a 67-year-old patient, known patient with ischemic heart disease and was on clopidogrel, fallen from stairs at home. And on admission, GCS was between like fluctuating around 13 and 14. Again, she had no other injuries. And because of the issue of the clopidogrel, we took the patient and got a CT done, and this was the CT scan. So in this patient, contrast to the previous one, you can see the cisterns are not uh, compressed, and you have enough space between the brain parenchyma, as well as not much of a midline shift. So this is another type of patient that we will get in our clinical practice, where they will have either they are on the very elderly patient, or they are on antiplatelets or anticoagulants. So in these patients, we have the increased risk of doing acute surgery, because by trying to do surgery, we can create larger hematoma in these patients, and there will be ongoing secondary injury by trying to do surgical evacuation for the patient. So in these kind of patients, again in Western countries, what we do is we put a ICP ball to monitor the intracranial pressure, and then we can observe the patient with both the intracranial pressure monitoring as well as clinical monitoring. And so if the patient start to develop increased intracranial pressure without much deterioration of the consciousness, then we can go ahead without surgical management, still with the medical treatment for the patient to reduce intracranial pressure. And but if the patient start to deteriorate clinically, even though like regardless of the intracranial pressure, most of the time it will be synchronized with the clinical presentation. But if the GCS start to become low, then always the clinical presentations and clinical deterioration has the priority over any of these measurements. So we will have to go for immediate CT scan, and we have to go for to decide uh, to go for either surgical management or to keep on continuing the medical treatment. So this patient, after the admission, she stayed with this fluctuating GCS. It was fluctuating around uh, 10 to 13, 14. So, but on the around 12 hours later, she started to deteriorate. So once the patient started to deteriorate, then we went ahead and did the second CT, and repeat CT. You can see what has happened. So in these patients, especially patients with anticoagulants and antiplatelets, the bleeding can be very slow, but can accumulate to a significant level. So in these patients, we have to go for what we call as say like delayed decompression or decompressive craniectomy. So this patient again went for a frontotemporoparital decompressive craniectomy, and but the good thing about uh, elderly patients is, regardless of the blood volume, some of them have very good outcome because the brains are very accommodating. So this is something that we have to keep in mind when we are managing patients with cerebral atrophy. So, few things about the decompressive craniectomy. There are uh, several instances that we will decide for surgical management or going for a decompressive craniectomy in patients. So, first type of patient is when patients who are presenting with refractory intracranial hypertension. So, you start with osmotic agents, sedation, head end elevation, and keeping normothermia. So when you try everything like this, but still the intracranial pressure is very high, then we have to go for decompressive craniectomy. And initially, like especially for patients who are presenting with diffuse brain injury, people used to do bifrontal decompression for these kind of patients, but the current brain trauma foundation guidelines uh, telling a little bit against for that practice, where if a patient needs a decompression, they are mainly advising to go for a unilateral decompression rather than for a bifrontal, because the patient's functional outcome has not been very good, even though we have saved patient's life. So we have ended up with severely disabled patients with this kind of decompression. Then the second indication is fairly straightforward. When you have hematomas, like I have presented, large subdural hematomas, extradural hematomas, multiple contusions on that one side, then all these things has to be evacuated. There's no other management. So we have to go for a decompression and evacuation of the clots. Again, when it comes to the hemorrhagic contusions of the brain and base of the brain hematomas, the current practice is not to go for removal of brain parenchyma, because there is some chance to regain the functional ability of the brain, and we consider the whole brain is eloquent rather than the old concept. So we should try to avoid removing parts of the brain unless you are having a significant edema and where you cannot close the brain at all, the wound. Then the third group of patient is patients presenting with severe head injury, and there are features of impending herniation. So you start with a bad patient, and where you have no other option, then you have to directly go for a primary decompressive craniectomy. So this is a scientific evidence to what I have explained for the surgical trainees. So this is a very famous trial, DECTRA trial, where they have compared patients with decompressive craniectomy to reduce intracranial pressure, and they patients went into a medical arm and a surgical arm. And what they have found is the long-term functional outcomes were not different in patients who had surgical management, and the patients who survived has worse functional outcomes from the surgical side. So this trial tells us that not every patient who is presenting with head injury has to have surgical management. It is up to individual patient, and it always has to be individual decision by a neurosurgeon to decide whether this patient needs surgery, because by having a patient who survive, it's not enough, because if you have a severely disabled patient, then not only the patient is going to suffer, the whole family is going to suffer with current day economic crisis and everything. Sometimes it may be merciful to let the patient succumb to death rather than trying to keep a patient who is like completely vegetative, where whole family will suffer. So that is something to keep in mind in surgical practice, especially like when we are sending a patient back to a primary care center or a peripheral hospital, we think all these things before we send. So sometimes you may feel like why this patient did not have surgery, but these are some of the things that we have to consider apart from thinking of a individual patient. We have to think about the management of the patients who have good functional outcome like children and patients like that, as well as the available facilities where we have to circulate all the facilities within the all the neurosurgical patients. So just remember that, and thank you.
මොකද්ද?
Can we start the next?
Yeah, no, you go.
So let's start. I hope everyone can hear. I don't know. Can someone confirm me?
Yeah, we can hear.
Okay. So basically, I'm Dr. Anandalal, consultant neurosurgeon at the Late Ridge Hospital, Colombo. We are sorry we had to change the timing. I was supposed to do this, but there was some issue, so we had to change it. So basically, I am here discussing important points in relation to intracranial pressure in clinical practice. Now, this is not necessarily related to trauma. This is in general for all the intracranial pathologies. So basically, what we mean by intracranial pressure is the pressure elicited by the contents of the cranial cavity on the cranial wall. So we basically have meninges, CSF, blood, and parenchyma. So any of these contents can contribute to intracranial pressure in varying amounts. And of course, we generally consider intracranial pressure to be around 10 to 15 millimeter mercury, but there is a significant variation of this than what we already believed before. So I have seen in overseas intracranial pressure monitoring is very commonly done. So I have seen an adult patient with intracranial pressure of 6 and he was absolutely fine. And intracranial pressure of 18 another patients, it was absolutely fine. So there is a significant individual variation. And of course, now certain basic science research has shown variations, kind of a diurnal variation also based on the temperature and sometime the hemodynamics, and also it's quite variable, but we generally consider 10 to 15 as the normal value. Uh, uh, in relation to anatomy related to intracranial pressure, structurally, the brain or the intracranial compartment is not necessarily isolated because it's a continuation with the spinal cord. But in relation to intracranial pressure, generally we consider the cranial cavity to be an isolated compartment. In fact, even certain studies have shown the pressure inside the spinal canal does not proportionally go up when the pressure inside the cranial cavity goes up. So there is some functional compartmentalization, and this has some clinical significance in certain management strategies. I'll tell it later. And of course, when it comes to children, there's a little difference because in children, the skull has some kind of degree of expansibility, whereas in adults, it's a rigid cavity. Obviously, we can understand. So the adult brain is quite vulnerable to for changes of the intracranial pressure because the wall can't expand. In children, the problem is a little less. So few causes of intracranial pressure which we commonly encounter in clinical practice. I have just categorized in the purpose of academic purpose. If you get in increase intracranial pressure, if there is any increase in normal contents, that's basically CSF, blood, and parenchyma. So generally, we see CSF, the volume of CSF more than the normal amount, which we generally referred as hydrocephalus. Blood, of course, not very commonly, but rarely you get a fairly high amount of venous blood congestion within the cranial cavity, which can actually cause increase in renal pressure. For example, bilateral jugular obstructions. Then, of course, parenchymal contribution is quite commonly encountered. Whenever there is cerebral edema, it occupies certain space within the cavity, causing increase in intracranial pressure. Then the second category is if there's abnormal content inside the cranial cavity. As we discussed, any hemorrhagic pathology inside the cavity where there's the hematoma can cause increased intracranial pressure. A little note about subarachnoid hemorrhage. Even though there is blood inside the cranial cavity abnormally, this does not cause increased intracranial pressure. But you generally see patients with subarachnoid hemorrhage coming with clinical features of increased intracranial pressure. That is due to cerebral edema. It's not due to subarachnoid hemorrhage per se. Because in subarachnoid hemorrhage, blood gets dissolved in CSF and there is no abnormal volume occupied. So when we get a referral into neurosurgery saying that there's a patient with subarachnoid hemorrhage and there are features of increase in intracranial pressure, we know that's due to cerebral edema, not necessarily due to subarachnoid hemorrhage. Similarly, when there is intraventricular hemorrhage per se does not cause increase in intracranial pressure because blood clot actually occupy the space within the ventricular system. But we commonly see IVH patients coming with features of increased intracranial pressure, and then we know that's due to secondary hydrocephalus. It's not necessarily due to intraventricular hemorrhage. Then, of course, tumors, where almost always there is abnormal volume occupied. And of course, infections like abscess and empyema. Then another little note about CSF infection. Again, CSF infection per se cannot cause increased intracranial pressure, but we see patients with meningitis and sometimes other intracranial infections coming with increased features of increased intracranial pressure, and that's generally due to associated edema or hydrocephalus. It's not just the infection in the CSF. Then in children, we commonly find another reason for increased intracranial pressure. That's a cranial cyanosis. The sutures are fused early in the life, and the cranial cavity volume is less. But the brain try to develop in the normal way, so there's increased intracranial pressure. Then, of course, in idiopathic intracranial hypertension and normal pressure hydrocephalus, there is an element of increased intracranial pressure, but the actual relationship we still do not know. There are so many hypotheses, but as these studies involve monitoring of intracranial pressure, it has shown some evidence of increased intracranial pressure, but it's not sustained increased intracranial pressure like what we see in other causes. And the clinical significance of ICP, and this is actually the real urgency in any neurosurgical pathology. That's why we don't actually bother to find out what the primary intracranial pathology when a patient comes with features of increased intracranial pressure, because the death or whatever the morbidity or mortality is primarily due to increased intracranial pressure. So we don't waste time to find out the cause in empirical emergency management. Uh, and the diagnosis of increased intracranial pressure is basically clinical. So you see whether there are any evidence in history, and you see whether there are any clinical features in examination. And most of the clinical features are non-specific. There are no specific features to say this patient has the increased intracranial pressure. One of the important thing we always see in history is whether there's any evidence of cerebral insult, because any cerebral insult can secondarily cause increased intracranial pressure. So if there is suspicions insult, we think of it. In examination also, there's one particular feature we always look for, that's the papilledema. Papilledema is a quite significant clinical feature to say that there's increased intracranial pressure, but all other features which I'll discuss later are not non-specific. Then, of course, imaging-wise, we generally do non-contrast brains in adults and sometimes ultrasound scan in children. And those two investigations are generally adequate enough to find imaging evidence of increased intracranial pressure. So we generally don't ask for other advanced imaging such as MRIs to diagnose ICP. And of course, all those things are clinical and imaging based. And if we really want to objectively find the ICP value, of course, there are techniques now developed, and those are in clinical practice. Both national level neurosurgical units in Sri Lanka has this facility, that's National Hospital Colombo and Kandy. But we do not generally use this, because if we put a ICP monitor into a patient, the monitoring and the patient has to be in at least a high dependence unit for the observation. As we don't have that facility adequately, we generally don't do, but this is the gold standard in looking for increased intracranial pressure. So basically, there are two devices we use. One is the ball that's inserted through the wall. Other one is the extraventricular drainage. This is basic principle of manometry, and this has added advantage because it's therapeutic too. If the patient is having increased intracranial pressure, we can take some CSF out to control it. So EVD has some added therapeutic advantage too. So I won't be going into technical details of this anymore. So few very basic management principles. Of course, definitive management depends on the cause. If you want to control ICP permanently as a solution, we need to find the cause and treat it. But I said the real emergency or urgency lies in the intracranial pressure and not necessarily the primary cause. So we always start with empirical management, non-specifically, of course, like head and elevation, analgesia, sedation, paralysis, and ventilation. All those things are important in bringing down ICP. Now, the problem comes uh, in each of these steps in certain instances. So we need to sort of clarify and customize it to the patient. For example, head elevation is a very good conservative measure to control ICP, but patient has to be hemodynamically stable. For example, in trauma, if the patient is hemodynamically unstable, we generally can't do this because cerebral ischemia can be worsened. Not necessarily, but it has to be in mind. Then giving analgesia also very good conservative management, but the problem is giving analgesia and sedation both affect neurological monitoring. So when peripheral units call me and ask, of course, there is a patient with some suspected intracranial pathology and there are features of ICP. Until the patient arrives to a neurosurgical unit, they are asking whether to give analgesia and sedation. Uh, I will say something, but that answer is not the standard answer accepted in developed world. Because if you give analgesia and sedation, we can't monitor, and we don't know when the patient is going to be deteriorated, and it can go into a life-threatening situation. But this is always done to control ICP because it's an easy thing to do. But of course, we need to have monitoring devices to check ICP if we are giving analgesia and sedation. But as we don't have this facility readily available always, it has to be a customized decision, and I don't think the primary physician or the neurosurgeons can take the responsibility of giving analgesia and sedation and later deteriorating the brain. It's just a system failure. We don't have the ideal situation to practice this. Same with paralysis and ventilation. It's a very good measure to control ICP, but you need to put ICP bolt or EVD to monitor ICP as the clinical monitoring is cannot be implemented. Then, of course, osmotic therapy. Generally, we go for empirical treatment with osmotic therapy also. But important thing that I want to mention here, if we suspect hemorrhagic intracranial pathology, I would say we need to consider mannitol as a contraindication. That's out in standard practice. But unfortunately, I still see even at late patients who are coming to Regi Hospital following head trauma, most of them are on being given mannitol. The reason mannitol is a very good osmotic agent to bring down intracranial pressure, but in the hemorrhagic pathology, there is high chance of expansion of the pathology because extravasation of mannitol. So we still use these, and even neurosurgeon advise using mannitol in hemorrhagic pathologies to buy time, but the patient should be able to go into neurosurgical theater within 30 minutes. Otherwise, the hematoma can expand, and the mannitol is the one which will kill the patient. So I would advise not to give mannitol if you suspect hemorrhagic intracranial pathology, both trauma, stroke, anything. Hypertonic is the safest hypertonic saline. We generally use 3% saline bolus according to body weight. And that, of course, I think even in standard practice, considered almost gold standard, even in empirical therapy, because that particular complication is not seen in hypertonic. In fact, if we have 20% mannitol, if we can give 20% mannitol bolus in a central line, they say it's equal to a decompressive craniectomy. So hypertonic saline is extremely effective drug, but of course 20% we don't generally use because of the metabolic complication. But 3% saline bolus you can give even if you don't know what the primary pathology is. But mannitol we don't give if you suspect hemorrhagic pathology. Tumors, infection, those conditions we still use mannitol. Then steroids again can be used empirically, but steroid work only for vasogenic edema, not cytotoxic edema. Now that is why in trauma, primarily we get cytotoxic edema, and there is no place for steroids. And unfortunately, still I see traumatic head injury patients being transferred mostly dexamethasone and sometimes even methylprednisolone, and that's almost out in clinical practice because in trauma what we get is cytotoxic edema, not vasogenic edema. And then acetazolamide is used to reduce production of CSF, and that's also effective management for ICP secondary to hydrocephalus. So if we don't know, or at least there are no evidence to suspect hydrocephalus as the cause of ICP, I will not advise starting acetazolamide empirically because that can also cause acid-base imbalances and metabolic complications. This I think Lakmal already mentioned. This is a very simple. I can't understand such a simple principle which everyone can easily understand, but this has a significant impact on some of the diagnostic and management strategies we use in neurosurgical practice. It basically says, Monropoli basically says your skull cannot expand, so it's a fixed box. And if there's abnormal volume inside it, to keep the pressure normal, some volume has to come out. It's such a simple principle, but has a extremely significant clinical relevance. So, a little bit about cerebral perfusion. Even though we talk about ICP, what actually matters for the patient is the cerebral perfusion, because the idea is to keep the cerebral circulation intact. So, relationship between perfusion and ICP is, so your blood, the brain is supplied, basically is governed by the mean arterial pressure, and the negative effect is coming from intracranial pressure. So the balance between mean arterial pressure and the intracranial pressure will determine the actual cerebral perfusion pressure. So generally, in otherwise healthy adult patient, mean arterial pressure is about 90, and if you consider 15 as the normal intracranial pressure, in otherwise healthy adult patients, cerebral perfusion pressure can be considered as 65 millimeter per mercury. Now, this pressure is the normal cerebral, is the pressure which need to keep the normal cerebral perfusion. Uh, and if we, for some reason, if the intracranial pressure is going up, now you can understand, unless we increase mean arterial pressure, your cerebral perfusion pressure is going to drop. And if the cerebral perfusion pressure drops below a critical level, then there will be inadequate cerebral blood flow, and that's what will cause cerebral ischemia. We consider generally as 4 to 6 minutes is the anoxic maximum tolerable period. But this is also extremely variable from situation to situation. But generally, if we cut off the blood supply to brain for 4 to 6 minutes, generally irreversible ischemia occurs. That's because of the lack of blood supply, and the perfusion pressure has dropped. Now, this is why we need to be alert on intracranial pressure, and we need to aim at managing strategies to keep the intracranial pressure at this particular value, so that the perfusion is maintained. In case if the ICP cannot be controlled, to keep cerebral perfusion, we will have to increase the mean arterial pressure. And this automatically happens with auto regulation, which I'll mention in the next slide. But of course, that has a limitation. We can't increase the mean arterial pressure as as possible, because that also has deleterious effects. There are the other clinical problem comes. A little bit about how these clinical features comes. Now, ICP has clinical features either due to ischemia, as I mentioned before, or due to herniation. Now, there are two phenomena that we see with ICP. One thing is when the ICP goes up, your cerebral perfusion pressure drops, so the blood pressure drops, sorry, blood volume flow drops, and the brain develops ischemia. And some certain category of clinical features are due to this particular ischemia. And of course, as the brain has internal partitions with dura, like pulse and tentorium, when the pressure starts to rise within a one compartment, of course, it can shift into the other. This is what we call brain herniation, and the rest of the clinical features in increased intracranial pressure is actually second bring up by this particular herniation. So we'll see what those are. Non-specific features of increased intracranial pressure, almost all the patient with abnormally high ICP comes with headache. This particular area also is extremely well studied in basic science. What we generally know now is dura is innervated very well by C fibers of pain conduction. And this causes very severe dull headache. Now we know C fibers carry slow pain or dull pain, which are not really localized. So if a patient comes and says a generalized headache, which is very dull, can be very severe, then you think of ICP as the cause. Of course, if the clinical situation is suggestive of. And like if someone calls me and said there's a patient with head injury and patient is complaining of occipital pain around occipital protuberance, which is very severe, I know that pain is not due to increased intracranial pressure, because increased intracranial pressure brings a very dull, severe, and generalized headache, because it's mainly due to dural strain. But apart from that, people think even the pressure transmitted to ocular compartment, as well as some degree of reticular stimulation due to, of course, I think due to hypoxia also can bring up this pressure headache. So, uh, and then there can be visual disturbances, there can be papilledema, as I said before. Then, of course, you get specific clinical features secondary to ischemia and then secondary to herniation. Due to ischemia, you can again get headache and nausea and vomiting. These are not specific, those are non-specific features, but almost always seen in when there are cerebral ischemia due to increased intracranial pressure. These are very well studied in basic science. What they think is now we know the area postrema, if you can remember the anatomy in the fourth ventricle. So that area postrema is a very sensitive area for ischemia. That's where the vomiting center is. So if you have ICP rising to a level where there is ischemia, patients starts vomiting. Uh, so that's also non-specific feature. Then, of course, alteration of consciousness. Obviously, when there is anoxia, neurons cannot function. So you see alteration of the consciousness. Then the convulsions. Convulsions also occur due to ischemia, because there are oxygen-sensitive calcium channels in glial cells as well as neurons, and there is it's a kind of toxicity actually, and it's thought to be calcium is the main culprit of convulsions in ischemia. Then, of course, cardiorespiratory changes. When the brain is ischemic, your cardiorespiratory centers, basically in the lower part of the reticular formation, can detect it. So you will see changes in respiratory rate, heart rate, blood pressure, all those changes. Then, of course, in the latter part of the ischemia, you will see pupillary changes, because when the brain stem is compressed with ICP, the Edinburgh vesical nucleus of the vagus is not going to function properly, and that's why we always see whether the pupils are dilated and fixed, and that indicates there's significant brainstem ischemia. Then, of course, if this goes into irreversible level, there will be death of neurons causing infarction. So basically that part of the brain will not function, and there will be clinical features relevant to that. This is just to illustrate how you recognize reversible ischemia and irreversible ischemia in the non-contrast CT. Here you see it's less blackish, but it's more blackish and well demarcated. So at this stage, it's not reversible. It's almost infarct, but at this stage, it may very well be reversible. These are the herniations. There are different types, but we are generally talking about three main herniations. One thing is if you have a lateralized mass effect, that part of the brain can be pushed to the other side below the funnels that we named as subfalcine herniation. Or else the temporal lobes can be pushed down across the tentorial edge. That's what we call uncal herniation or the temporal herniations. There are different clinical features specific for those locations. And of course, if there is a generalized increase in intracranial pressure, the whole brain content can be pushed down to the foramen magnum, which we call brainstem herniation or coning. That actually occurs as the terminal event when the pressure is generalized and above a certain threshold. So here I have mentioned those different types of herniations, and you have specific clinical features which can be attributed to these different sites. So I'm not going to go into detail of it. Uh, One important thing about coning, because we get a lot of neurosurgical referrals, not necessarily in trauma, but even in other neurosurgical pathologies like infections and tumors. Uh, Referrals coming as emergencies because they are GCS3 either hemodynamically unstable, pupils dilated and fixed. And then what we tell is to send the patient immediately to the nearest station where a non-contrast CT scan can be done. They don't have to be sent to a neurosurgical unit. Now, this is one of the messages that I want to give. When we get a call from a faraway place, they primary clinicians always want the patient to be sent to a neurosurgical unit. That is not necessarily because we are struggling a lot with ICU care and extremely high operative neurosurgical workload. We would prefer to see whether the patient is in a position, suitable position to come to be accepted to a neurosurgical center. So we generally advise not to say transfer to a neurosurgical center, but to send to a nearest place where the non-contrast CT is possible. Because we basically want to see whether there's any point in transferring. We basically want to see whether their patient is going to cone. So I said ICP is the pathology you see in any primary intracranial disease. And of course, coning is the terminal event in almost all the neurosurgical pathologies. And if the coning is such a stage where nothing can be done, such patient is there's no point in such patient being transferred to a neurosurgical unit. So what you do here is you get a new non-contrast CT done, and you go down to the lowest most cuts and select the cross section which goes across the foramen magnum. And then you see, now you see the medulla here, the brain stem, and these are the two tonsils, lowermost part of the cerebellum. And you see a blackish ring around the cerebellum here and a blackish area just posteriorly. Now, this is the CSF cistern around the brain stem, and this is the lowermost part of the cisterna magna. Now, this black color indicates there is CSF around it. But if you go to the other PT, now you can't see this black color ring or the black color pool of CSF here, which means your brain stem here is compressed by the two tonsils. This is what we call tonsillar herniation or the brain stem herniation. So the whole brain is pushed down through the foramen magnum. This is what we call coning. And when you see this stage, there are this is the radiological or the imaging evidence of coning. But of course, this doesn't say the patient is in terminal stage clinically. Now, this needs to be interpreted along with clinical findings. So, if you have a patient with this CT and you say patient is GCS3, pupils dilated and fixed, he is hemodynamically unstable, I am not going to accept that patient to neurosurgical unit despite whatever the agency and despite whatever the primary pathology you see in the CT because that patient is dying. There is there is little chance that we do something and get the patient's life back, but the patient will be vegetative. And we know in our country, even the living people cannot live now. So I don't think the creating vegetative patient is the best option in neurosurgical practice in this country now. So if I see this CT and you say patient GCS is 8 and patient is hemodynamically stable, is pupils 3 millimeter and reactive, I will ask immediately to transfer to nearest neurosurgical unit. But if you say GCS3, hemodynamically unstable, pupil dilated and fixed, and this is the CT you have sent to me, I will say this is not for neurosurgery. This needs to be palliated. But of course, neurosurgeons are prohibited to suggest to go for organ transplantation. But that is the situation where you should contact organ transplant teams and see if they can do anything. Of course, after discussing with the family. But we will not suggest that because neurosurgeons cannot involve. But that's the ideal management, and that's what happened in all the countries where there is a standard neurosurgical practice. But unfortunately, in our country, there are a lot of various reasons we still go for decompressive craniectomy. So whatever the management strategies, still for most, I don't know most, and I quite commonly see we are actively doing things for this, mostly because To be honest, the other people do not understand the actual situation here. That's actually the truth. So there's a little, I don't think I need to discuss this. This what happened when there is spawning, your brain stem is compressed and ischemic and it's going into irreversible ischemia. And we know in the medulla oblongata, the lower part of the reticular formation has the respiratory center and the cardiovascular center. So you see all the cardiorespiratory changes when the patient goes into coning. Uh, this is how you get fixed and dilated pupils. That's also not going to discuss here. Um, so a little bit about how does brain tackle ICP. Now there are various. I think if you think about all the organs of the body, brain has the most efficient compensatory mechanisms, but of course fail also quickly. So what happened is now that's why I said the Monroe-Kelly doctrine is a very basic principle, but that is what's being operated here. So if you have some positive agent causing increased intracranial pressure to bring back the pressure to a normal level, brain has to send out some volume. So what brain does is first it remove the most unwanted material which is there in the intracranial cavity, that is the CSF. It performs an important function, but that's the least significant component if you compare it with the other components. Then once that is done and reach the maximum level, then the brain starts to send out venous blood. And when that also goes to a certain extent, then the brain starts to take in arterial blood because that also can control the volume inside. But at this stage, now we know when or even if the almost all the CSF goes out, not a very big, you get clinical symptoms, but it's not a very big issue. Venous blood also, majority of venous blood can't come out from the brain, but still the brain can survive. But when the brain starts to do this to restrict arterial flow, then of course there's a problem because if of course brain is trying to prevent ICP going up, but of course, that will create ischemia too because there's no blood coming in. So all the clinical features of ischemia will start when the brain reaches this step of controlling ICP. Then once that's also failed, the brain start pushing itself out. And that's the terminal event, which is spawning. This is a very simple explanation that I just created to understand what's happening inside the brain when there's increased ICP, but it's very complex than appear here. But this is just for the understanding purpose. Uh, I think so. What happened is now to keep cerebral perfusion intact, your mean arterial pressure should rise when there's rise in ICP. So if now when this particular pathological process operates, if there's a ischemia in the brain, the first thing is the ischemia is detected by the brain stem. Basically, it starts from the reticular formation, and there where you get the lower part of the reticule in the medulla carry all these vasomotor centers, and that detects the ischemia, and this increase the sympathetic outflow to the body. So we have sympathetic outflow to the heart as well as peripheral blood vessels. And what happens when there's an increase in sympathetic outflow? The heart rate goes up, contractility goes up, and the vessels is contracted. So your diastolic and systolic blood pressure rises. So that is how the body operates to bring up main arterial pressure to keep the cerebral perfusion pressure intact when the ICP is high. So, but what happened is when the blood pressure is brought up, this is detected by the baroreceptors in the carotid and the aortic arch, and the signals goes in again to the brainstem. Those are glossopharyngeal and vagal afferents. And that stimulate gives a feedback to the brainstem saying, of course, the blood pressure is too high now. And this is detected now. These glossopharyngeal and vagal afferents goes to the Edinger vesical nucleus of the vagus, which is the parasympathetic output. Now, what happened here is parasympathetics we know goes into heart, but not into peripheral blood vessels. So the previously increased heart rate and contractility is little brought down, but there's no effect on the blood vessel contraction. So blood pressure will drop a little, but stays high still, but your heart rate will drop. So next stage, at this stage, you will see hypertension with bradycardia. So initially you had hypertension with tachycardia, and then you develop hypertension with bradycardia. This is what we call Cushing's reflex. So it's basically a mechanism to keep mean arterial pressure high, to keep the cerebral perfusion intact when the ICP is high. So there are two stages of Cushing's. First stage, you have hypertension with tachycardia, and the next stage, you have hypertension with bradycardia. At the initial stage, we do not recognize as Cushing's because hypertension is tachycardia is what the normal hemodynamic response in the regulation of heart and blood vessels. But when it's reached the second stage, we know that's the actual Cushing's. So it's basically a compensatory mechanism. This is the autoregulation. Now, mean arterial pressure or even cerebral perfusion pressure within this range, the blood pressure stays, sorry, the blood flow to the brain stays static. And that's why I said the brain has the most efficient compensatory mechanism because a wide range of pressure change keeps the blood flow to the brain static without significant change. This does not occur in other organs. When the pressure drops, blood flow also drops. When the pressure rises, blood pressure or blood flow also rises. But in brain, it stays static. Right. Okay. So there are a few experimentally proven mechanisms how it keeps in this particular static state. I'm not going to go into detail, but that's what the compensatory mechanism operates here. So we'll quickly go into probably the most important part. So there is now we need to recognize when we get a patient with the increased ICP, it's a process, a dynamic process, and at which stage patient actually lies. For descriptive purposes, this is divided into four categories, but it's a continuation. You don't see a abrupt shift from one stage to the other. But for understanding purposes, I also have categorized it into four with arbitrary values. So these values are not the absolute correct values, but for the understanding purposes, I have put this description. The stage one is in intracranial pressure is a compensated phase. That means you have all the compensatory mechanisms being operated to tackle ICP. So generally, this happens when your ICP, because I said around 10 to 15 is the normal value. But even if ICP reaches up to 20, still you won't see much changes in physiologies because all the compensatory mechanisms keep cerebral perfusion intact. So brain is compliant, rising pressure is accommodated. And I said now brain has this mechanism to put whatever the unnecessary things out from the cranial cavity. And at this stage, probably brain push out only the CSF, not blood, the initial stage of handling volume. That is when CSF doesn't perform much function, so patient doesn't feel anything, not anything, but feel very little. And the hemodynamics are normal because your brainstem is not ischemic, so there are no sympathetic or parasympathetic activations. Cerebral blood flow is maintained, cerebral perfusion is maintained. All the compensatory mechanisms are active. So there is no ischemia, no herniation, and patient should be alert. Generally, patient GCS cannot be less than 14. It has to be 15 or 14 if the patient is in this particular stage. And in this stage, the management is conservative. I said you can elevate the head and give sedation, give analgesia, all those things will be effective in managing this particular stage. Then moving to second stage, this is where generally ICP reaches 20 to 25. These values are very arbitrary. This is only for the understanding purpose because I said there's huge variation of this, but it generally comes within this range. And now the brain is little compliant because most of the CSF has gone out, and next step is to put some venous blood out to keep the ICP normal. So the ICP itself mechanically compress venous compartment and ICP itself mechanically compress arteries, but there's arterial pressure also. So there is some degree of because we know venous compartment is compressible. So that's the easiest to put out. When this happens to arteries, of course, when the arterial flow is getting limited, the ischemia starts to develop. So at this stage, patient starts to develop features of clinical features of cerebral ischemia. This ischemia is detected by vasomotor center, as I said before, and to increase cerebral blood flow by increasing cerebral perfusion pressure, autoregulation operates. So the initial part of the Cushing's. So there will be tachycardia, hypertension, tachypnea, and you have some degree of ischemia, but at this stage it's probably reversible. So if you do something, the ischemia will reverse. And you won't see any herniation if you do a CT at this stage. And generally, the patient GCS will be 14 to 12. It will never be less than 12. But this is not very solid, but I'm just telling it will be within this particular range. And here is the place where you aimed at medical management of ICP, like giving an osmotic therapy, of course, with the previous conservative measures too. And generally, medical management is effective in this particular stage. Your ischemia can be reversed, ICP can come back to normal. Yeah, once the ICP is back to normal, these compensatory mechanisms will be back to normal. So your tachycardia will disappear, hypertension will be disappear, and the patient Jesus will improve to 15 if the patient is not going to go to the next stage. And if that also fails, now this is just an illustration of how the ischemia occurs when the perfusion pressure. So the stage three, basically you get a decompensation. That's basically your Cushing's starts to fail. At this stage, the ICP is generally within 25 to 30, and the brain compliance is almost lost because everything which can be safely sent out is now sent out. So remaining is the brain parenchyma. So that is not safe component to be sent out. And the autoregulatory mechanisms are now failing, cerebral perfusion is dropping, and the second stage of Cushing's, you will see the actual Cushing's. So you will see bradycardia with hypertension. And generally, at this stage, the GCS will be less than 12. Now, something that's important, which I want to mention here, we get quite a lot of emergency neurosurgical reference from peripheries, and when they call me, they say there is evidence of Cushing's, so we think this is a neurosurgical emergency. Then my question my next question is what's the GCS of the patient, and sometimes they say GCS 15. Now that is not Cushing's. Then I don't bother. I don't take for that patient until there is some evidence to say that there is intracranial pathology, because you can't have a patient with Cushing's having GCS 50, because now Cushing's means there is cerebral ischemia and the body is trying to compensate for to bring to resolve that ischemia. So at that stage you can't have proper normally functioning neurons, and which means you can't have a patient with a GCS of 50. So if you have a patient with hypertension and bradycardia and the GCS is 15, even if you suspect the intracranial pathology, the ICP is not high. That is not Cushing's. That is why neurosurgeons don't generally sort of make a big fuss to bring the patient into a neurosurgical center, because we know that is not Cushing. So that's some other hemodynamics change. Uh, yeah, that's what I want to do. And in this particular stage, generally the management is surgical. So you need to do imaging definitely, and you need to find what the primary pathology is. So basically, primary pathology needs to be addressed to control the ICP at this stage because it's very severe. So what we do is we either remove the clot or we drain the CSF through a drainage tube, sometimes lobectomy, sometimes decompressive craniectomies. Now, all those things are needed at this particular stage. So, this particular stage is a real neurosurgical emergency. Now, if all these features are there, we don't even ask to image the patient. If the facilities are not available, we ask the patient to be transferred to a neurosurgical center immediately because it's a life-threatening, and this is what the real neurosurgical emergency is. Stage 3. Then, of course, the last stage, stage 4, is the decompensated phase of ICP. That means all the compensatory mechanisms have failed, and Cushing's is completely failed now. Now, I said at the latter part of the second stage of the Cushing is hypertension and bradycardia, but when the brainstem is completely ischemic and there is no autonomic output to your circulatory system, your heart functions drops and the vasculature function also drops. So you get hypotension with bradycardia. So if you have a patient with suspected ICP and patient develop hypotension with bradycardia, that means the neural input to circulatory system has failed. That means going into terminal, probably irreversible brainstem ischemia. At this stage, generally ICP, not generally, almost always ICP is more than 35. And there is no compliance at all because everything that can be sent out to keep the volume intact is sent out now. And only thing remaining is to send the brain now. That means the brain parenchyma will be pushed into spinal cord through the foramen magnum, which we identified previously as coning. Now, this is the stage where coning occurs. So auto-regulation is lost, Cushing's has failed. So there's bradycardia, hypotension, bradypnea, and there is significant cerebral ischemia, which is irreversible, going into coning, and GCS can never be above 8. It's always below 8 because it's such a significant cerebral injury. And generally, what we see is actually the patient with a GCS of 3, but can never be above 8, and pupils will be dilated and fixed because the Edinger-Westphal nuclei is completely ischemic, or maybe in a significantly high intracranial pressure, there's bilateral oculomotor nerve compression too. Then, of course, at the end, the patient will go into respiratory arrest and die. So the management of this particular stage is basically palliation because everything has failed. Sometimes we still ask the patient to be immediately transferred to neurosurgical center, but almost always when the patient reaches us, patient has gone into cardiorespiratory failure. So at this stage management, it's a failed brain. So despite any aggressive management, death is the consequence. Very rarely, patient might survive if he immediately decompress, but they all go into vegetative state. So I personally, but generally neurosurgeon do not advise doing anything active at this particular stage because it's a failed brain. So in developed world, this is the stage where there's brainstem testing, active palliation, and organ donation. But in our country, there are very many reasons we still go for active management and lose our resources. And I actually don't know how to correct that. When I was a trainee, very junior trainee, I can remember there was 4 ventilated patients at our room in HSL, and it's a road traffic accident, and we got urgent CT brain. All 4 brains had this particular CT, this coning, and they all were going into irreversible ischemia. So I said the room staff, all 4 is going to be transferred back to where they came. So people were very unhappy. So there was, I can remember, there was school child, and there was one ventilator bed available in neurotrauma unit. So including medical staff were asking me, "මේ අනේ මේ පොඩි ළමයාවත් කරන්න බැරිද?" Because that's our attitude. We think we need to do something, but this is prohibited. This contraindicated, prohibited in developed world. Uh, and to be honest, once I did a decompressive craniectomy for such a patient when I was in overseas training. Till I leave this station, they were sending me audit inquiries asking why you did this. Because it's a waste of money, waste of resources, and we are compromising our resources, which can be made use to for patients who actually need neurosurgical care. So this is the ideal management. Ideally, this has to be should come from intensive care specialist and organ transplant teams, because neurosurgeons cannot involve in transplant procedures. But that is the ideal management in this particular stage, depending on, of course, of the pathology. So that's basically what I wanted to mention. Some basic principle in relation to important clinical important in clinical practice. But if we have time, I can quickly go through one case scenario. Do we have enough time? Uh, there is no response, but if there's time, I can quickly go through this case scenario. Just to highlight one practical point, let's say this 35-year-old motorcycle rider collided with the lorry and brought to the hospital within 30 minutes by a non-medical team. So on admission, GCS is 13. Basically, patient is obeying. His blood pressure is 160 over 90. Pulse rate is little high, little tachypneic. His pupil is 3 millimeter and reactive, moves all four limbs. And there's the bleeding scalp laceration, and they have done X-ray. There is the skull fracture, linear skull fracture, and the bleeding scalp wound. So basically, they have put IV cannula, analgesics, normal saline drip, and the pressure bandage to the wound, and then transferred to neurosurgical unit. This is a very common clinical scenario we encounter as the receiving end in neurosurgery. So when the patients arrived at neurosurgical center after 2 hours, let's say, patient GCS is 3, pupil 6 millimeter, dilated and fixed. Blood pressure is low, pulse rate is low, and irregular breathing, saturation 84. So basically, he is in cardiorespiratory failure and neurologically unstable. At when the patient came to the local hospital, he was stable. He only had a bleeding scalp laceration and a linear skull fracture. So the management here is intubation and ventilation, and then fluid resuscitation, and patient was sent for urgent non-contrast CT. And this is what we have seen in the agent non-contrast CT. Now you see this brain is blackish in color. You can't see any sulci and gyri. It's basically effaced. There's only a little bit here. Ventricle is effaced, and gray and white matter demarcation is completely lost. And this is what we call global cerebral edema or global cerebral ischemia. And there is a fracture which has moved away from the normal position from of the skull, and there is underlying contusion with a little bit of bleeding hemorrhage. So what has happened? According to the imaging findings, findings here, this patient is either has hypovolemic shock with increased intracranial pressure, or maybe coning. because according to his clinical picture. So he had a depressed skull fracture initially, and now it's outwardly moved, which means it's a floating segment. And why it has moved outward here is because of the intracranial pressure. It has actually auto decompressed. The pressure itself has pushed the fractured segment away. This is basically a protective mechanism. The patient's ICP is to a certain extent accommodated. Uh, then, sorry, sorry. Then underlying focal injury, hemorrhagic contusion, and there's ischemia and edema. So the clinical context here, patient had a linear skull fracture seen in X-ray, which is the primary injury. And there's a depressed skull fractures, and the only thing that happened was the patient's transfer from the peripheral unit to the neurosurgical center. And during that period, the linear fracture has become a depressed skull fracture because it's moved out now. It's actually depression now moved out because of the pressure. Now, this is the iatrogenic injury. So, what has happened is now the patient has actually had the depressed skull fracture, which is seen in the X-ray as a linear fracture because you can't really see unless there's a significant depression. So, you have put a pressure bandage, and that pressure has actually converted the linear fracture into a proper depressed skull fracture. So, it's an iatrogenic injury. And there's underlying focal injury may be primary or it can actually be a iatrogenic also because you are putting pressure with the bandage and the fractured segment will go and hit the brain, and that may be the reason why he has a hemorrhage and contusion underlying, or it may be primary too, but it had no mass effect. Now, this particular hemorrhagic pathology does not need any neurosurgical intervention. It does need the conservative management because this is going to resolve. But now the whole brain is ischemic. Now, this is not at this stage of conservative management. So there is global cerebral ischemia, which is secondary brain injury. So you have three types of injuries here. Primary injury, then there is iatrogenic injury, then there is proper secondary brain injury. Why, how he has got this secondary brain injury? Uh, the evidence for that is patient has developed ischemia, global cerebral ischemia. So what has happened is there has to be some bleeding. No? The patient already had bleeding scalp wound. Patient probably has bled to shock, and there's hemodynamic instability, it's basically circulatory collapse, causing lack of cerebral perfusion, which is the secondary injury. And what's the cause? The bleeding scalp wound. What I wanted to highlight here is a scalp wound bleed with a little less than aortic pressure, and that bleeding can cause death. And that is not theoretical, that we will quite frequently see significant bleeding from scalp wound. Patient have been transferred from peripheries with a pressure bandage. And we know aortic pressure, let's say mean arterial pressure is 90, and it's not easy to put even pressure of more than 90 with the bandage. And when the patient generally present with this particular injury, the patient is in severely distressed situation with pain. So the all the autonomic responses are there to cause tachycardia and hypertension. So your pressure bandage should have very high pressure to arrest bleeding from these scalp arteries. So it's not easy to keep a bandage with that adequate pressure to control bleeding from scalp wound. And anyway, these bandages generally, when they reach national hospital, these bandages are generally out because it's not going to stick into the head. So that is what has happened. Though it's a very commonly done practice, this bandaging with pressure bandaging is not going to work for actively bleeding scalp wound. So that is how this patient has got secondary cerebral injury due to circulatory insufficiency. Another thing is when the pressure is going up within the intracranial cavity, if there's a depressed skull fracture, that is actually protective because the skull fracture will add some more volume. So it's like a auto decompression. And by doing a pressure bandage, you actually prevent that auto decompression. So you actually cause intracranial pressure rather than treating it by a pressure bandage if there is a depressed skull fracture. So the patient ICP will go up and patient can go into coning. So this is what particularly what's has happened here. So secondary brain injuries here is completely preventable, but once it's established, of course, we cannot do anything. So for the management of scalp bleeding, it can be lethal. So the pressure bandages are not going to be the best. It can work, but we are not quite sure. We are not 100% sure. It can be ineffective. It can convert linear fractures to depressed fractures, and it can nullify the effect of auto decompression. So the best management I personally suggest for peripheral units, if they are transferring a patient who has got a active scalp bleeding, to suture it, not to apply pressure bandages. And the suturing, the patient it's not necessary the patient to go to a theater. There is no need of sterility. There is no need of general anesthesia. It's a kind of I think it can be considered as damage control principle because we generally try to prevent bleeding to keep the hemodynamic stability and to prevent further damages secondary to ischemia. So it's just mass suturing. You can do it at emergency unit. Use a thick, non-absorbable suture. Asepsis is enough. Just pour the betadine on the wound. We don't need sterility. And just local anesthesia. And you can actually do even without local anesthesia, I suppose, when there's significant injury. And that's the sole purpose of this particular suturing is hemostatic. It's not a cosmetic suture, and the receiving end, the neurosurgeon or the trauma surgeon at the receiving end cannot blame at the peripheral unit for doing a ugly suturing because the idea of this surgery is damage control hemostasis. It's not a cosmetic surgery, and that can prevent secondary brain injuries in traumatic brain injury situations. And when you suture also, you can just continuously suture the two edges of the skull. And only thing is now if you see the layers of the skull, your blood vessels are in this particular adipose tissue layer. So above that you have dermis, below that you have the gallia. Now those are the toughest two structures in the skull, and luckily your bleeding vessels are in between these two. So what you need to do is you approximate dermis to the aponeurosis and block this space so the blood's coming out from this particular potential space is blocked. Idea is not to approximate two edges of the wound. Idea is to approximate the dermis into the aponeurosis in the one particular edge. So that is what prevent bleeding. Now, why I am mentioning, I have seen a nice suturing, but when the patient, particularly in pediatric age, when they reach us, still they have do a nice suturing, but patient has gone into circulatory collapse because you have approximated the two edges, so the blood is not coming out but bleeding inside the this particular space. And in a child, bleeding into the scalp is enough to cause circulatory collapse. So what you need to approximate is the dermis into the aponeurosis, not necessarily the two edges of the wound. This is particularly important in children. Another thing is when there is an injury, cut injury, we know the aponeurosis here, the gallia is attached to muscles, the frontalis and the occipitalis. And the frontalis and occipitalis goes into spasms. So these two gallial edges are retracted from the wound edge. So if you see the wound edge here, the gallial edge is not here, aponeurotic edge not here. It's at least 1 centimeter away from the edge. So if you want to approximate the dermis to the aponeurosis, you should catch at least more than 1 centimeter away from the edge. Then only you can catch the actual aponeurotic edge. Then only your hemostasis will work. So this case is just to highlight this particular simple maneuver that we can do before transferring a patient with active bleeding, a scalp wound, because this is very commonly we see, and this is very important in pediatric neurotrauma, because you will do a surgery to prevent bleeding, but still it can bleed if you haven't done a proper technically accurate suturing with this anatomy knowledge. So this is what all I have got to tell, and thank you very much. Can someone finish the session now?
So, excuse me. Hello, sir.
Yeah.
I have a doubt. They have in the case of a contusion. So, do we have to
Uh-huh.
repeat the NCCT in 24 hours in all the patients, even though the GCS is not dropped?
Yeah. If there is a hemorrhagic pathology seen in a CT, we generally advise minimum 24 hours observation, because the maximum risk is within 24 hours. It's compulsory for a patient with a contusion to stay in a place where the neuro observation can be done at least for 24 hours. What we generally do is, when there is concern or the suspicion of injury, uh, we always observe them in an institution for 24 hours. But if there is CT evidence of some of a pathology, sometimes we prefer, depending on the severity of the pathology, either 48 hours or 72 hours. But definitely 24 hours if there is any evidence of injury, because there is the risk of expansion of hemorrhagic pathology within 24 hours.
And so, if the contusion is converted to this hemorrhagic pathology, so is it possible to differentiate this hemorrhagic pathology from the evolving hematoma? That's the contusion is become liquefied.
It's possible, but it's little technical, I suppose. Now this one is a hemorrhagic contusion, and it's not ICH, but I suppose that's too radiological and too neurosurgical, and we don't need to bother to differentiate the hemorrhagic contusion from ICH, because management is, I can't say the management is the same, but if it is there to a surgical extent, of course the management is the same. Even hemorrhagic contusion with a significant mass effect, we prefer taking out if the ICP is high, if it's not settling with conservative management, and same goes to the ICH. So I don't think in a peripheral unit, we don't have to really bother to differentiate the ICH from a hemorrhagic contusion. Anyway, we can take neurosurgical opinion if you send the images to a closest neurosurgical center through some kind of online uh, media. Like what we generally do is we ask the peripheral units to transfer the images through WhatsApp, and then we give the opinion.
So can you explain the current evidence and practice of prophylactic antiepileptic management?
Uh, uh, yeah, so current evidence is, despite any traumatic brain injury, there is no strong evidence to recommend anti-epileptics prophylactically, because we don't know which patient is going to develop post-traumatic epilepsy or convulsions, and it's not predictable. So standard guidelines generally do not advice, and most of the standard centers also do not do that, but there are individual differences in some neurosurgeons, depending on the pathology, and it depends on the severity of the pathology, where the pathology is seen, and the vulnerability of the patient to develop convulsions and all. Some neurosurgeons recommend a short duration of anti-convulsions, but if you go into the standard literature, they will clearly say there are no strong evidence to recommend anti-epileptics despite the severity of the traumatic brain injury, because there are patients with very mild traumatic brain injuries. You won't even see anything significant in the CT scan, but they develop convulsions. But there are very extremely severe pathologies seen in CTs, but they never develop convulsions. So because the causation of convulsions is not strongly related to the severity of the pathology. So it's not recommended, but I can say there are significant variations, and some neurosurgeons still prefer. Generally don't start prophylactic antibiotic in any traumatic brain injury unless there is evidence of convulsions, either clinical or EEG, because sometimes we keep the patients paralyzed and ventilated, and sometimes GCS low. It's needed intubation and ventilation. In such patients, you can get convulsion, which you will not see, will not see as the patient is paralyzed and sedated. So if there is EEG evidence of convulsions, of course, you need to start. So I generally start anticonvulsions if there is clinical evidence or neurophysiological evidence of convulsive activities only. And most of the UK centers also do the same, but I'm not quite sure about the other places. And we have only 12 neurosurgeons at the moment. I know some of us still recommend anticonvulsants. So can we stop the lecture now?